Hold my son all day long.
Immunotherapies that train your body's healthy cells to seek and destroy cancer cells.
Go back, get my PhD.
Advanced radiation therapies that target cancerous tumors to avoid harming healthy tissues and organs.
Not sure, but it'll be a good day.
All so you can stop thinking about the day you were told you have cancer and start thinking about the day you may be told you don't. Another reason why your life is worth Penn Medicine.
The COVID-19 pandemic sent shockwaves throughout our healthcare system, especially in communities that shouldered greater burdens because of racial and economic disparities. Cancer screening, care, and clinical trials proved especially challenging. In a study of health centers that serve lower-income patients, mammogram screenings dropped by 8% among women aged 50 to 74 in the first 2 years of the pandemic. That could mean hundreds of missed cancer diagnoses. And cancer cases could increase by 10 to 14% this year. Yet innovative providers found new ways to connect with patients and families throughout the pandemic. Today on Inquirer Live, we look at the challenges and lessons of the pandemic and what they could mean for more equitable healthcare in the post-pandemic world.
Good afternoon, everyone. I'm Charlotte Sutton. I'm the managing editor of the Philadelphia Inquirer, and I am your host today for this important, and I think it'll be a very stimulating discussion about the future of cancer screening, care, and trials as we hopefully move out of the COVID pandemic and move forward. First of all, I'd like to thank our sponsor, Penn Medicine, for bringing us this program today. And secondly, if we welcome questions from our audience. So if you are watching us at inquirer.com/live, you can submit questions in the comments section at the bottom of the watch page. If you're watching us on social media, please join us at inquirer.com/live to add your questions. We have a truly extraordinary panel of experts joining us today, each of whom has a unique perspective on these issues. In our hour-long program, our goal is to provide you with an introduction to the enormous, complicated, and very newsworthy topic of cancer care for all. I hope you'll feel inspired to Google all of our panelists and learn more about their work. Right now, I'm going to give just the briefest round of introductions before each of these accomplished professionals speak for a few minutes about what they are doing to make healthcare more equitable and available to everyone who needs it. I'll start out with Sherry P. Erkman, MD, who is a professor of thoracic medicine and surgery at the Lewis Katz School of Medicine at Temple University, where she is a professor at the Center for Asian Health and also leads Temple's innovative lung cancer screening program. She focuses on lung and esophageal cancers and the science surrounding screening decisions. Next is Dr. Carmen Guerra, who is an internist and vice chair of diversity and inclusion in the Department of Medicine at the University of Pennsylvania and is associate director of diversity and outreach at Abramson Cancer Center. And her projects include bringing colon cancer screening into neighborhoods. Finally, we have Dr. Edith P. Mitchell, who is clinical professor of medicine and medical oncology at the Sidney Kimmel Cancer Center at Jefferson, where she founded the Center to Eliminate Cancer Disparities in 2012, and she is now director of diversity. She's the former president of the National Medical Association, the largest and oldest national organization representing African American physicians and their patients in the United States. She is currently the editor of the NMA's journal and has authored and co-authored more than 150 articles and book chapters, as well as many abstracts on cancer treatment, prevention, and cancer control. So like I said, there's a lot out there to Google. At this point, I'll also note that we were hoping to welcome Carrie Connor Matchett, who is a tireless advocate for women dealing with breast cancer. Unfortunately, Carrie is not feeling well today. She has lost her voice, So she sends her regards, and we will get her back here in the future because she is just a terrific speaker and a real inspiration. So let's start out. I wanted each of our speakers to just speak for a few minutes about what your work is doing to help bring us closer to this goal of cancer, of equity in cancer screening and care and trials. So Dr. Erkman, do you want to kick us off and tell us what you're working on these days?
Thank you. I'd be delighted to. And thank you so much for having me speak among these very distinguished co-participants. We're working on lung cancer screening. So we do know lung cancer is the #1 cancer killer. And I think there's a lot of stigma. There's a lot of self-blame that people with lung cancer feel. And so part of that is really getting the word out that lung cancer, if it's found in early stages, is treatable. And thankfully, we do have clear evidence that lung cancer screening with a CT scan can decrease the chance of dying from lung cancer among high-risk populations. And in terms of disparity, we know, Temple, in our neighborhood, in our community, that lung cancer has incredible impact. It affects African Americans and Blacks greater than other populations. Later diagnosis, also mortality, morbidity, access to care are all issues. And so what we're trying to do is to really bring education around lung cancer and lung cancer screening to make it more accessible, to make it less frightening, and to get people screened when they're at high risk. So it's difficult. It's not like breast cancer and colon cancer where we know, okay, everybody needs to have it, women and all people above a certain age with colon cancer. For lung cancer, the criteria is, you know, more difficult with pack years, 20 pack years, and people between the ages of 50 and 80. So even with these few restrictions on screening, it makes it harder to communicate what is high risk, what is not high risk, and who's eligible. So those are some of the challenges that we're facing in getting the word out about lung cancer and screening, and especially to the population that is high risk.
Great. Dr. Erkman, thanks. I know we'll be talking more later about exactly how you're achieving these goals, but thank you for those opening remarks. Dr. Guerra, can you tell us what you're working on these days?
Sure, Charlotte. Thank you. And thank you for the invitation to also speak with these wonderful panelists. As you saw in the video, which is, thank you so much, is from Penn Medicine and our work in the communities. I lead a team, a very large team of staff and faculty and even trainees that you saw out there, some of the PhD students in the community, trying to essentially decentralize cancer screenings by taking them out of the clinics and into the communities, and thereby avoiding many of the barriers that keep our patients from accessing those screenings. And those barriers are immense and insurmountable. They include anything from knowledge, beliefs, and attitudes which have to do with the patient, but enormous system barriers such as the lack of insurance, the lack of transportation, inability to make appointments, health literacy to really understand the instructions to prepare for these cancer screenings, out-of-pocket costs, things that we don't think about, such as parking costs. And so if we are able to take out cancer screenings out of our clinics and hospitals, we thereby avoid many of these barriers. And so that's the vision. And what you saw in the video was actually us trying to do that with our test case, which is colorectal cancer screening. So for colorectal cancer screening, patients have a menu of options that they can choose once they turn 45 to be screened. They include colonoscopy, but as we know, that's a very complex test. So what we were doing out there was actually providing FIT tests, fecal immunochemical tests, to individuals over age 45, which is a simple take-home test. And we were so proud to be working with our partner, Enon Tabernacle Church. That's where the video was taken. And through their partnership with us, we were able to also not only get the word out and engage people, but also they were a site for the tests to be returned, or they could be mailed in to us. And so we were able to pick up the tests there several times a week, bring them to Penn, develop them, and then call people with their results and send a letter to their doctor. And so a simple take-home test. And that's our test case, as we said. And we hope to do more in this space as the technology for cancer screening continues to improve. And we can get into that later if you'd like. But that's been my role, and that's the vision that we're working for at Penn Medicine, and more to come, hopefully, as we can really understand who the right partners are, and the technology improves, and we develop a workforce that can do this, that can successfully engage communities and do it in a responsible and respectful way.
Okay, great. Thank you so much, Dr. Garrett. And Dr. Mitchell, what are you working on these days?
So thank you so much for the opportunity to work with this illustrious panel today to talk about our work in Philadelphia, and to emphasize that all of our centers work together. So one of my efforts is developing collaborative endeavors that allow people to work together. And I have worked both with Penn Medicine and with Temple through our Sidney Kimmel Cancer Center at Jefferson to increase collaborations. We cannot do it alone. Mm-hmm. And one of the things that I work on is developing relationships with primary care physicians throughout the city and actually throughout the world. I have relationships in other cities as well as other countries, with the idea that if we all share our education, our techniques, our efficiencies that work together, we have better outcomes and results. So one of the things that I've developed is working with physicians who practice in neighborhoods in Philadelphia where there is a higher either incidence rate for 5 cancers as well as higher death rates. And these cancers include cervical cancer, breast cancer, colorectal cancer, prostate cancer, and lung cancer. So it's working with all of these areas such that with the primary care physician who takes care of patients who develop all of these different cancers at some point, we are able to target our screening. And if we screen for all 5 of these cancers early on, while the patients have no symptoms of any cancer, we're able to find the cancers prior to the patient developing pain or weight loss or other problems related to symptoms from cancer. And with that, we find that in some cases, we're able to actually prevent cancer. And that is in cervical cancer. Cervical cancer actually can be prevented in about 95% of cases if the screening recommendations are followed, and if the patients undergo those screenings according to guidelines. And that is what I'm working on. And if we've even find a cancer, if it's asymptomatic and the patient is not having pain or other problems, then the treatment for those cancers is likely to be associated with better outcomes. And better outcomes means that the patients can actually be cured of the cancers, can have prevention of cancers in some cases, and therefore absolutely total better outcomes. So it's working together with our partners, and that includes primary care physicians for education on the latest developments in screening, the latest developments in prevention, and the latest development of treatments for patients with cancer. And then we have a new area that we are working with, and that is treatment and management of the patient that is cured of cancer. I'm also on the President's Cancer Panel, and this is the President of the United States, where we are working with expanding these opportunities and educational access throughout the United States. And of course, President Biden, in his recent address in February to the nation, indicated that he would like for us to see that cancer patients don't suffer as in the past, and that we see our patients with new developments of treatment and prevention. So we see cancer in a different way in the future. And he also indicated that he wanted to decrease the cancer mortality rate by 50% over the next 25 years. And consequently, preventing cancer or either diagnosis of cancer early prior to the patient becoming ill or having problems from the cancer is the most important way to do this. Consequently, the three of us work together with our respective institutions in a unified and collaborative way to decrease cancer death rates in this country. Thank you.
Okay, great. Well, that is a wonderful primer for our conversation, so I really appreciate that. So let's just jump right in. Dr. Guerra, last year you spoke to one of my colleagues here at the Inquirer, and you made some interesting comments that I thought about the whole issue of, one of the barriers that keeps some people out of the medical system or from fully engaging with the medical system. And you said that you've been trying to work with healthcare providers and building trust, and I quote, rather than saying the patients are distrustful, which sounds like blaming the victim, to change the framework to think about the trustworthiness of research institutions. Tell us how that works in practice, because there's been so much talk about, communities of color don't trust doctors because of the Tuskegee experiments. But you're saying that this issue should be handled straight on and not just taken as accepted.
Yes, Charlotte, thank you for the great question. It's actually part of a national dialogue right now, and it's paradigm changing or mind frame changing to think about trust that way. It was actually the topic of this year's American Board of Internal Medicine, trust, because we've recognized that trust is actually an incredibly critical thing and precious thing that can be easily broken between ourselves, healthcare providers and researchers, and our patients and participants. So that changing of the mind frame to thinking about ourselves as trustworthy, what does that look like operationally? So it really means first understanding history. Many people don't understand where their institution's history has been, what's our history with our communities. And it's interesting because we at Penn and at other institutions, we recruit every year, every July 1, we have new medical students, new trainees, and we just plop them in to, start providing care, often without that background. And so first, I think you have to learn what is that history between your institution and the community so that you don't go out to communities looking naive at minimum, but at worst, by not understanding and respecting that history, you start off on the wrong foot in building a relationship. So for me, that actually meant understanding what Penn, has historically, what their relationship with the community has been, and specifically researchers at Penn, and learning some things that maybe, we're not proud of anymore. And we recognize we're wrong and have, openly apologized to our community members for that research and the way that some people were treated. And if you don't know that, it's going to come up in communities, and you want to be able to at least be aware of it, and perhaps even say, I'm sorry on behalf of institutions. So that's how you begin to repair those relationships. I also think it means putting your agenda away, and going to communities and listening. And I mean, really listening. And that doesn't happen very often. It seems so simple, but I have to tell you that most people don't leave their workplaces and go out to communities, right? To really get to know their community and really understand what are their needs and how can we help you. So it's a lot of work. It's hard work. It's not easy to do. And it's time consuming. So I've spent, over a decade trying to do that. And then the third thing is, I think it means building relationships with partners that can be potentially your own navigators as you begin this process. For us, as I mentioned before, Enon Tabernacle Church has been a wonderful partner for us. And they've been able to not only help us navigate through this new relationships that we were trying to create, but also be those influencers and messengers to get the word out that, they need health care, and we're ready to help work with them. And then, not just listening to what their needs are, but doing something about it. And so that often means going back to the healthcare systems that you work and working with other people that can help deliver some of the needs of the communities. And the last thing I'll say is, communities often have a lot of assets too. So it's not just a one-way relationship where you're as a health system there to provide care. They have lots of important assets, including networks, that if you begin to understand those assets, you can then work with them to use those same assets to provide better care to communities. So I hope that helps to maybe more clearly define how we begin to build trust and assume that burden is on us, the researchers and the healthcare providers, and hopefully shows how, it is hard work, and it's a long-term goal. It's not something that you can earn really quickly, do your research project and leave. I think that's harmful to building trust. And so I hope that clarifies a little bit of how we viewed this journey, which we've been on for years and years, and continue to grow our relationship with our community.
Absolutely. So at this point, I have to ask Dr. Mitchell, I don't want to date anyone, but you have certainly been working in this space for a good long while. And when you started out, what would you have thought if you had colleagues saying, we have to respect our patients and meet them where they are and work with them and recognize their strengths? How revolutionary would that have been when you started?
So thank you so much for recognizing that I've been doing this a long time. And in fact, I started when I was 3 years old. I grew up in the rural South, and my great-grandfather became ill at age 89. I was 3, and he and I were very close. So with his illness, I overheard family members and others talking about how they would take care of him and that they couldn't take him to the hospital because Blacks were not treated appropriately. So I said to him after a physician came to the house for a house call, and I said to him, "Pa, when I grow up, I'm going to be a doctor just like Dr. Logan, and I'll make sure you get good health care." Wow. So I've been doing this a long time. But one of the things that's so important, especially in Philadelphia, that we have to understand our history. And I call it looking through the rear view mirror at what has happened in this city. So although we have great institutions, the Black graduates of both Jefferson and Penn did not allow Black doctors to obtain residencies and training here in the city. And our doctors had to go elsewhere. So with this, there is the history of Mercy Douglas Hospital in Philadelphia, where Mercy was found by one Black doctor from Jefferson, who had graduated from Jefferson, and another, Douglas, by a Black graduate of Penn. These two hospitals eventually merged, and they were the only sites in the city where Black doctors could get training in surgery and other medical specialties. And it was the only place where many residents of Philadelphia could get medical care.
And what's our time frame here? I'm sorry to interrupt you, but how long ago are we talking here?
So about the early 1900s, 1906, okay. I think one was formed, and the other about the same time, and then they merged. Okay. So this is really very important, and people in Philadelphia remember that. When I am talking to patients or other entities, they will tell me, I was born at Mercy Douglas Hospital, and so forth. There is also the historical program of the report published in 1910 of the Flexner report that was supposed to reinvigorate medical education in this country. What it ended up doing, closing 7 Black medical schools, leaving only Howard University in Washington, D.C., and Meharry Medical College in Nashville, Tennessee. Those were the only 2 Black medical schools left, because other major institutions did not accept many students until the mid-1960s with the Johnson's, President Johnson's Great Society. Black students had nowhere to go for medical education, and consequently, the number of Black doctors dropped substantially and has not recovered. It's still only about 5% of practicing doctors in this country are Black. Yet when you look at minority populations, Blacks constitute approximately 13% of the population in the country, but less than 5% of practicing clinicians. So in addition to going to the communities, and yes, I've been working with Enon Tabernacle for several years. I've been working with physicians in the community to increase screening, to increase participation in clinical trials with their patients. And I say with their patients because this is a collaborative idea. Patients just don't come to you and expect to enter clinical trials. In fact, for clinical trials provided to the FDA in this country, less than 2% of those patients are Black. So we need to increase the number of clinical trials. We also need to improve and enhance the number of Black doctors in the country so that we've got a larger cadre of individuals focused on education, early screening, treatment, participation in clinical trials. And these are physicians who are in the community and therefore reaching the patients. And again, collaboration among our institutions. And Dr. Guerra and I do this together very frequently. So it's really working to try and improve the overall medical care, healthcare, cancer prevention, cancer treatment in our Philadelphia communities.
Yeah, absolutely. Well, so much of what we're talking about here is outreach and communication. And Dr. Erkman, I saw a video from the Society of Thoracic Surgeons where you were talking about some of the strategies that you've used at Temple to overcome some of the barriers to lung cancer screening. And as you can imagine, I'm all about telling stories. So I was really intrigued when you said that one of the most successful strategies has been using patient stories. Can you talk a little bit more about how that helps you reach people who are otherwise maybe not eager to hear your message?
I think that's a really important part. A little bit of what we were just discussing is that how do you get a message across? How do you become a trusted messenger of health information? And many times you're looking at physicians who do not match up against the population that they're serving, that they maybe the population is of one background, one socioeconomic background, and then the physician and research group is from a different one. So it's really important that we look at exactly what we're discussing, workforce disparity, and that we get people who are physicians taking care of patients to become a trusted health information source. But even more importantly is exactly what you're saying is that members of the community themselves can speak so much better about their experience and how they felt, and really sharing their stories lowers the barrier of uncertainty. And so we have a lot of patient stories that we're sharing through podcasts, through videos, through Zoom links, and just asking people what's your fear about lung cancer? What's your fear about screening? And they're shared among many people, and just being able to get the get the fears out there and to discuss them and say, well, how did you overcome it? And what was the benefit of overcoming the fear of screening? And then you get the message. Well, we were able to detect cancer in early stages and treat it effectively. So everything that we're saying here is exactly a multifaceted strategy to increase screening, prevention, and care in populations that are oftentimes neglected. So getting patient stories out has been really helpful, not only in educating our patients, but also educating other doctors and researchers and understanding. I didn't really think about that perspective, and I didn't understand that that was such an overwhelming fear, that many times people are so scared about finding out about lung cancer they rather not know, or
Mhm.
they're fearful that they're going to be castigated for smoking, and you should, this is your fault, you shouldn't be smoking. But then now our doctors can have a much more open um, perspective, that people are really looking for help, that their fears are addressed, and it's been a really wonderful way to not only share stories of patients but family members, and also of some of our providers as well.
Hmm. You know, when you and I were talking a week or so ago, I was really intrigued by what you were doing at Temple during the pandemic when, we all know how difficult and kind of frightening it was to go into a medical facility. Can you share with our audience what you kind of came up with, this sort of hybrid model of, because you couldn't hand out fit tests in parking lots for lung cancer screening. You have to use the high tech gear. So how did you go about making that work?
We're fortunate that our institution, our Temple leadership, really prioritized lung cancer screening, and we came up with a system whereby patients can come in for their low-dose CT scan. They come into the radiology area at a specific time, but then we would report the results to them through telemedicine. So either through a phone call in the beginning when we didn't have things set up with Zoom, but then later on we were able to establish a telemedicine platform. So we were able to do shared decision making. Is this the right thing for you? Is lung cancer screening right for you? Then to arrange the visit for the CT scan, and then they go home, and then they can receive the results of the scan through telemedicine. And we found a lot of advantages to that, in that people oftentimes felt more comfortable receiving the information at home. They could have their family members with them, where if they came into the hospital, we were isolated and only one person could come in. And it also turned out to be very convenient for patients. And it's not a perfect solution. Certainly, there are people who are challenged by technology and access to technology. But we did study 400 patients who did telemedicine, and 400 patients who did in person, and we didn't find any difference in terms of the race or ethnicity makeup, or even the age, meaning that people were willing to participate, even our older folks who we were worried about accessing technology. And we were also able to see that there wasn't any difference in terms of education levels between telemedicine and those who did preferred in-person visits. So it's not a perfect situation, and certainly people would like to visit in person, but there are people who would rather visit in telemedicine, and this hybrid model gives us a lot of options to access as many people as we can.
Okay. I at this juncture, I just have to ask, because there is a lot of education to be done in terms of screening for lung cancer. What are the general guidelines for who should be getting and you're talking about spiral CT scans primarily, or?
Right. So this is a low dose CT scan. You don't have to take your clothes off. You don't have to do a bowel prep. You do a low dose CT scan. It's roughly 5 minutes. And this has to be at a qualified institution or radiology center. And the people who are eligible are people between the ages of 50 and 80 with a 20-pack year smoking history, which means roughly smoking a pack a day for 20 years at least, and actively smoking or quit within the past 15 years. And it's difficult to remember this criteria. There are a lot of different resources and you can access it, but it's also difficult because these criteria change very rapidly. In fact, we just had a change of recommendations in 2021, and CMS is now reimbursing it with the new criteria recently this year in 2022. So these changing criteria, they're important, they're specific to make sure we screen the right people, but it also poses a challenge because we need to educate not only our communities, but also our physicians and community partners.
Yeah. To me, that seems like
so I'd like to add that that's so true in order to obtain the scans for the patients. But it's also important that we educate the insurance companies, because many insurance companies don't know that CMS has approved it and don't know that the low dose CT scan is what we use for screening for lung cancer. And many insurance companies interpret the request for a regular CT scan or 3D CT scan, and they're all different. So it's really educating everybody involved, the practitioners, on how to order the test so that it is successfully covered, but also the insurance companies to make sure that they cover the cost of the low dose CT scan for the patients.
Interesting. Now, Dr. Mitchell, you and I were talking the other day, and you expressed some concerns about the reliance on telemedicine. Can you talk a little bit more about what you're seeing with the patients you're working with?
Certainly, telemedicine has been a godsend for managing patients, especially since the pandemic. And the use of telemedicine has increased by approximately 10 times that level of use prior to the pandemic. But we must understand that there are limitations to the technology. First of all, a smartphone is really important, but not all individuals, especially the elderly population, has access to smartphones. They use the old flip phones. And in some areas, even in Philadelphia, there are no towers to allow for the technology that is important. And we actually did a program in education with some school in Philadelphia, and the kids did not have access at home, and they would go out and find a business. They would go out in the streets, find a business where they could lock on to access from that business, and the kids were utilizing that. There are also areas in our Pennsylvania and other communities, so covering Pennsylvania, New Jersey, Delaware, and southern New York. There are areas where people cannot receive telemedicine because of lack of towers. So there is actually a proposal going through Congress now, and the various commissions involved to make cell phone use available throughout the United States. So working with our congressional members, we can influence the need for this in the delivery of medical care in this country. So a lot of work ongoing, both within our state, but also in the country to increase the availability of telemedicine for every citizen. There's one insurance company that plans to provide either cell phones or iPads to all of its members. So insurance companies involved, because it saves money for all of us if we're able to have the technology and utilize recommended guidelines. So I thought that was very innovative for one insurance company to say that they will provide access tools like an iPad to every member in their insurance plan.
Yeah, that is really something. On the other side of like media savvy, if you will, I thought it was interesting, Dr. Guerra, when you and I were talking about the interest in colon cancer screening. We were talking about the untimely death of an actor. Can you talk a little bit more about how public events like that could perhaps help bridge gaps between communities and medical facilities?
Oh, sure, absolutely. Every once in a while, we will have the unfortunate death of someone very prominent, and the media then carries that news to communities, and it begins to reverberate shockwaves in the communities. And the particular one that you were talking about is in August of last year, Chadwick Boseman's death, Black Panther. And as a result of his death, many people who adored his work and movies and the person that he was, really felt incredibly traumatized by that event, as if they knew him personally. And but he represented so much to people, both in his role and in real life. And so when that occurred, we were called by some of the communities to talk about not only how it was impacting the community members psychologically and emotionally, but also the fear that it had created in them. Fear that the way they saw things, that if someone like Chadwick Boseman, who had everything, could die of colorectal cancer, he had his youth, he had wealth, he had fame, resources, networks, access, then they felt, quote, as if I don't stand a chance. And that's what was relayed to our team. And I know from my prior work that fear can be paralyzing. We've talked to so many community members that would rather not know, and therefore they don't want cancer screening because they're so afraid that a cancer screening will tell them that they have cancer, when in fact the majority of people are told they're fine. And so we have to work with them to help them understand that, you know, most people are actually fine, and it's a peace of mind to have a negative screen. And so that was a conversation I think I'll remember for the rest of my life, because I remember thinking, how can I help my community during this really difficult time where I don't want the fear to paralyze them. I want it to lead to more screenings. And so what can I do? And that's what actually set off the conversations with Enon Tabernacle Church about what we could do together, which led to us working together on the program that you aired earlier. So it was a really, I think for me, it brought home several things about how these events in the media like yours that you carry, that important news actually impacts people to potentially either retreat in fear, or how can we as healthcare providers and institutions use those opportunities to actually help people take the right next step. And I'm old enough to remember also when Katie Couric's husband also was diagnosed with colorectal cancer. And then that was a media opportunity that she knew. She was clever to know the power of the media and how to use it to actually help people into action by then undergoing a live colonoscopy on television to show people you can do this too. And this is what it involves. And so I would love for us to think about, you know, partnerships with the media and the community, so that when these things happen, we actually help our communities make the right decision for their health and keep our community members as healthy as possible.
Sure. And I would like to add to that, Craig Melvin on NBC News and his brother dying of colon cancer at a very young age. And certainly Katie Couric's husband was very young. And that brings up another topic of colorectal cancer, where it is increasing in young individuals less than age 50 by 2% per year over the last 10 years. So we're seeing colorectal cancer in a younger age population. And whenever a celebrity can give information in the news media, what you find is that screenings increase. And the same thing happened with breast cancer when former First Lady Betty Ford revealed her experience with breast cancer. Breast cancer screenings increased significantly. And I always say that collaboration with our community, with our health policy members and legislators and congressional members, it's so important that we all collaborate and work together to define the best practices, to define the health policies that we need for our state, for our community, so that we can increase the amount of work that we are doing through health policy. One group that we are working significantly with, and that is the Congressional Black Caucus. And certainly we have Representative Evans, who speaks for us not only in Congress, but he speaks to the community, and he has appeared at a number of our community events for screening. Again, it's everybody working together. And I also say that the members of the news media, you are an important collaborative partner in getting the word out. For example, breast cancer screening, we had a group, and I'm not talking about one TV station, but NBC 10 set up a bank of phone callers or phone answerers to answer questions. And we were able to give out 10,000 copies of a breast cancer information tool to our callers. So the news media, like the Philadelphia Inquirer and others, are very important to getting the message out to our
Right.
community.
Well, and on that very topic, in the time we have left, I'd like to kind of do a rapid round of questions here from our viewers. Interesting question here related to the pandemic. We all know Dr. Ayla Stanford and the amazing work she's been doing for COVID screening and also vaccination. And Dr. Erkman, I believe that you've been able to, maybe piggybacking is not quite the word, but you've been able to kind of link into the interest that the COVID screening and vaccines have shown to also bring in more awareness on cancer screening?
Right. It's interesting. I think the shared resource concept is really important because you shouldn't reinvent the wheel for every single cancer subtype and for every single disease.
Mm-hmm.
You already have community partners for cancer screening, which we did, and to pivot that to now we're going to use those vans that we did for breast cancer screening and bring messaging and vaccines out about COVID. And then at the same time, we also have information about lung cancer screening and colon cancer screening.
Mm-hmm.
So it's very interesting that we're able to leverage our relationships and our knowledge and the progress that we've made in, say, colon cancer screening to jump off and use that same mechanism for spreading the word about vaccination or lung health or smoking cessation, which impacts many different cancers. So definitely exactly what Dr. Martin is saying is exactly what Dr. Guerra is saying, is that we need to use the shared resources that we already have to
Mm-hmm.
efficiently get the message out.
And that could very well be the answer, although I'm sure, Dr. Guerra, you can elaborate on this. Another viewer is asking, how do we ensure access and equity to all people who are seeking screenings and preventive care?
Yeah, great question and a fundamental one in our society at present day. I would say there are two answers to that. One is insurance and having all people have access to some form of insurance. And, I know that there are states still without, for example, Medicaid expansion, which has been shown to lead to increased cancer screenings and increased diagnosis at an earlier stage of cancer when it's more treatable. So we still have a lot to do in that policy world. And then I would say the second thing has been shown to already work, but we haven't implemented widely and universally, which is navigation. Navigation has been shown to really help individuals overcome all of the barriers that they face, and those vary by person. And so navigators are able to elicit what are those barriers and meet the patients where they are by eliminating those barriers that they face and helping them complete cancer screening tests. So I would say broadening the insurance access and navigation programs. And part of the reason they haven't been expanded is because no one pays for navigation. So essentially the hospitals and the clinics that provide it, such as the hospitals that are represented here today, often have to pay for that on their own. And there's no reimbursement code for providing those patients with that help. Sometimes we are lucky to have philanthropists who understand the value of navigation that have helped those hospitals fund those programs. But other than that, it comes out of our bottom line. And so those would be two essential things in my mind. I'm sure the other panelists have other ideas as well, but I would start with those.
Great. What would anybody else add on the topic of how do we ensure access to screening and preventive care?
So in addition to what Dr. Guerra said, in those states with Medicaid expansion, there has been an improvement in access to cancer treatment and earlier initiation of therapeutic interventions for patients. So that's another benefit. We also have the CDC programs for cervical and breast cancer screening that we utilize extensively. And I just got an invitation today for increasing the expansion of the CDC program for underinsured individuals for breast and cervical cancer screening. So that's a program that we can focus on. And the important thing about the navigators are really extensions of our institutions. They know the community, they know the benefits and the opportunities that we have at the institution, so they can inform and educate individuals in the community about the opportunities, for example, for cervical cancer screening. And then in Pennsylvania, we have a way of getting the patients onto Medicaid quicker if they qualify for Medicaid, so that therapy, if cervical cancer or breast cancer is found and the individual has a gap in the insurance coverage for treatment, that we can get the patients onto Pennsylvania Medicaid much faster and more effectively, so that there is no time deficit in terms of patients having initiation of their treatment and appropriate treatment.
Thank you. One last question here. I think it's a really good one. A viewer is asking, what advice might you have for family members and caregivers support for cancer patients? And I would add to that, what do you do? And Dr. Erkman, since you're dealing with a screening that is less familiar with people, if you have someone that you love and you really want them to go get screened and they're not really into it, what's the best way that you can support them to get the screening and the care they need, do you think?
Well, I think we touched on the idea of fear and what happens after the screen. And I think helping people understand the step after the screening. What if it's negative? What are the steps to decrease your risk? Quit smoking, follow up with your doctor, general health concepts. But then if it's positive, what happens? And I think people understanding the step after screening, that you can have successful treatment if it's caught early, that there are caring physicians and institutions who will help you get through that process, that will definitely bring people the support. So it's not just screening and then this ledge of unknown. I think that's the best way to do it, is just to help inform your family members, inform your communities that there is life after screening, for sure.
Well, that is a wonderful note to end this program on, that there is indeed life after screening. And I thank you all so much. This has been such a wonderful conversation. We could keep it going on a long time, but we are out of time. I'd just like to mention, we've got such a lovely comment here from a viewer who says, thank you so much for all this information. Here we are, and the work these panelists are doing. Distrust of healthcare professionals by people of color is historical. The clarion call has been heard. Thank you again for the changes. And so thank you again for participating, and thank you to all of our viewers, and thank you to Penn Medicine for sponsoring our conversation. Everyone have a great rest of your day, and we'll see you the next time on Inquirer Live. Thank you all.